So last week we talking about physical examinations on the head and neck. So we talking about the physical examinations. Start from the head, and then we go down. We go to the neck first. Then we will go to the chest today. So still remember when we're talking about physical examinations, we have 4 ways to checking. Looking. First way, just look or inspections. Second way, palpation. Means use your hand to feel different part of the body. Third way, percussion. Percussion is a special kind of way. Especially today we will talk about the chest. We will know how to percussion. And then aspirations means your scalp. Special kind of scalp to hear the sounds coming from the body. So that's the physical examinations way. So when we checking different parts, we may only use a couple of them. Some part we may need to use all of them. So it's depending different part of the body. So in the head part, we mainly use inspection or looking. Mainly use inspection and looking. So like we looking the hair and we looking the scalp area to see if some abnormal kind of situation in there or it is just normal. And we also looking to the scalp, like the shape, and especially for the children for fentanyl. And then in the face area, we have orifice in there. Orifice part, some of the orifice we just looking, like the mouth and the throat area. Some orifice maybe we have some special checking way, like the eyes, like the ear. So that's depending which part of the orifice. So that's generally inspections part, and we're talking about especially for the children. Usually it's under 2 years old. Usually it's under 2 years old. We need to be careful for the fentanyl is closed or not closed. So checking the eyes, we have some special way. So this picture is checking for the vision field. Like just compare practitioner's vision with the patient's vision. Should be the same. Should be the same. That's normal. If practitioner can see, but the patient couldn't see, that's abnormal. And another checking way, we're talking about a special test, and then put something in front of the eyes and try to like focus there. So that's another checking for the eyes. convergence. Yeah, convergence. So that's checking two eyes commonly focus on the same subject and moving. So that's some special way when we checking for the eyes. And another, we checking reaction for the light, flashing light type. Means normally, normally, both eyes, the pupil should be same size. Like dark in the room, pupil little bit bigger. And outside, sunshine, pupil little bit smaller. So basically, it controls how much light go to inside the eyes. Too light, they will be smaller. Too dark, they will be bigger. So that's the normal reactions. When people use, like in the dark room, when people use a small light close to the eyes, the pupil will be changing from bigger to smaller. That's normal reactions. That's basically we can test by the two side eyes one by one. Then checking for the ear, for hearing. We can speak some low sounds close to one side of ear, and then like patient repeatedly what they heard. So like people coming to clinic, they say my hearing decreased, but he didn't know which side. So basically we can separate the types. Checking for the nose. Normally, certainly we can use special kind of scope looking inside the nose cavity. But for physical examination, basically we checking the sinuses. So we have 4 pairs, but basically we only can checking 2 pairs in the superficial of the body. 1 pair is the frontal sinuses. 1 pair is the maxillary sinuses. So that's it located. Basically, we just pushing. Use our fingers to pushing local area. Then patient feels some tenderness or even painful. That means some inflammations happens in there. And the most part, basically, we just looking. Most part is looking. That's outside mouth. The skin, some skin rushing in there, basically is hyper. So that's for the head part. Then last week we also talking about the neck examination. Neck examinations, we separate a few parts. So we examination for skin and skin nodules. And also we like moving the neck to see if there are stiffness. So normally will not stiff. It's easily to move. And then we checking for blood vessels. We have an external jugular vein in the neck area. But normally, people sitting there or standing up, we couldn't see it. Normally, when people lay down there, we can see it, but not more than 2/3. We calculate from clavicle bone to the angle of the jaw. That's normal. Even we see it when people lay down there, but not that longer, still normal. Then we checking for thread gland. So that's the mainly 3 part in the neck area we're checking. If we find some nodules, we can record like it located, thus the anterior triangles. We can record where it is, where it is. And or maybe it located on the posterior triangles. Basically, by the muscles here, that's big muscles, and they have to hide, separate these two triangles, and with trapezius muscles here. So that's just the anatomy area. And thus we're talking about the V here, external jugular V, this one. So this one we say, normally people sitting there, standing there, we couldn't see it. But when people lay down there, we can see it. But not bigger, that's the jaw angle here. That's the clavicle bone here. So distance from here to here, we divided with 3 equal parts. Not over here. That means 2/3 here. So if over here, like this patient, even go to here, we still can see it. So that's abnormal. Yeah, that's abnormal. And even this one, yeah, this patient look like sitting there. When she's sitting there, usually we couldn't see it, but this patient truly we can see it. Yeah. So these two pictures, both abnormal. Yeah, both abnormal. Right now we just try to know which one is normal, which one is abnormal, and certainly go to individually illness, and then they will talk about what kind of illness caused abnormal. Then we look at some nodules on the neck. So that's behind the ear, that's nodules here. So that's basically we just try to record where it is. So that's basically inspection part. In the neck, we also can use palpations. Physical examination way, we have looking or inspection, palpation that we can use on the neck. So basically, we are inspection first. Then we find something, we will palpation it. So that's we checking the neck. So like we put hand behind the patient's both sides of the neck and then try to palpation it. So both sides should be normal and softer there. And we also can holding the trachea with one hand and then palpation to other side and then switch. Then we checking for thyroid gland. Yeah. When we checking for thyroid gland, usually we stand behind the patient and put our 2 hands in the neck area to see both sides is the normal size or maybe some nodules inside. So that's the normal or thyroid gland. look like an H, and both sides same size. Usually pretty softer, and you are a little bit hard to separate the soft tissue on the neck and the thoracic gland. But if patient got sick or illness in the thoracic gland, we can see it, and then we can palpate it. Yeah. So that's truly pretty bigger here. So that's abnormal condition. Another part with palpation for the nodules above the clavicle bone area. That we call supraclavicle. That means over the clavicle bone there is look like a divot there. So when we palpation here, we need to put our fingers a little bit deeper here, and even ask patients deep breath in, and then we can push in pretty deeply here. So usually we try to find some nodules there. So that's basically physical examination on the head and the neck area. And the common symptoms, relationship with the head and the neck. That's pretty common one, headache. Yeah, people coming with headache. Headache may caused by a lot of reasons. Yeah, like eyes problems can cause headache. Nose problems can cause headache. Even sometimes ear problems still can cause headache. So we will lot of reasons. Then we checking to find what reason caused headache. And another symptoms, vision changing. Vision changing certainly, that's mainly is eyes problem. Then we have the way checking for the eyes. And the double vision, still mainly eyes problems. And the hearing loss, tinnitus, earache, even vertigo. That's mainly relationship with ear problems. Then we checking for the ear. Nose bleeding, that's nose problems. And sore throat, that's mouth and throat problems. Then the neck basically is the throat problems. So that's basically coming from last week. We talking about physical examinations in the head and the neck. Any question in this part? Yeah, I think you just try to find some like family members or friends together and do some practice. Okay, so today let's go to physical examinations in the chest area. That just means chest. Yeah, it means chest. So a lot of medical words is different with usually we use. Yeah. Thoracic just means the chest. Yeah, just means chest. Like when you talking about point location, you're talking about in the level of T1 to T12. What are you talking about? Just in the chest area, thoracic vertebrae. And we're talking about physical examination lung first for today. Certainly in the chest area, we have two important organs. One is the lung, another is the heart. And we're talking about we have 4 ways make our physical examinations: inspection, palpation, percussion, aspirations. All of these 4 ways we can use both for the lung and the heart. So that's certainly a big part physical examinations. We can get a lot of information from our 4-way physical examination. So we separate with 2 classes for the chest area. Today we mainly talking about the lung and the general chest area. Next class we go to the heart. So when we're talking about checking for the chest, we're talking about some anatomy symbol first. Yeah. Surface symbols like in the chest area. Yeah, the chest area. So let's look in the picture. Maybe a little bit easier here. So above the sternum bone here, we have a divot here. There's a divot here. So this part we say superior, which is separate words here, means above. Yeah. Superior, that's sternum bone. Yeah, that's sternum bone. Start from here, and certainly all the way down to here. That's sternum bone. Sternum bone separated with 3 parts. That's the upper part. So above the sternum bone, or we have a notch here. Notch just means the divot here. So this area we call superior sternal notch. Yes, superior sternal notch. When we talking about the sternal bone originally is 3 bones. So 3 bones originally, and then they fusing together. Yeah, they fusing together, form one bone right now for the adults. Yeah, for the adults, we say totally people have 206 bones for the adults. But for the children, much more than that. Yeah, much more than that. Like 300 something. And gradually, when children grow up, some bone and bone fusing together. Thus, our numbers decreased to 206. So that's one example here. Sternal bone originally 3 bones, but 3 bones later fusing together. But when they fusing together, it's not totally flat there. They form a small angle here and small angle here. That's just the fusing part. Even they fuse into one bone, but we still can know or can feel it because they have angle there. So that's we call it steno angle. So in your anatomy class, you still learn that steno angle. And that's the above one. And the lower one, still. So infra means lower. Yeah. Sopa means above. Infra means lower. So Y is above, Y is lower. We have two angles here. On the sternal bone, yeah, on the superficial sternal bone. I believe if you touch it, you can feel it, at least the upper one. So that's here. And this name, mandible, just the first part of the sternal bone. Yeah, first part sternal bone is called mandible, and then the bigger part, which is called the body. Yeah, the body of the sternal bone, and the small part, yeah, small part, we call it xiphoid process. So that's three parts and the name. Then about the clavicle bone. So here is the clavicle bone. About it, this area, we still use the same medical words here. Supera and the clavicle fossa just means kind of a divot area. So that's some anatomy location. So if we find something, we can mention where it is. And certainly follow the vertebrae. We can talk about in which of the, like between which ribs or which intercostal space. That's the anterior part. Then posterior part. Posterior part is more important. We have scallop bone here. In the scallop bone, we have pretty big bone. We call it process. So when formed above it, still a divot there. Still we call superior scalpel regions. And then below it, we still use the same words. Infra scalpel region. Some books even still use fossa. Yeah, the same idea. So that's around the scallop bone. Then we have special area. This area, that's the 12th rib. That's spinal column. So between it, form an angle here. So this angle we call costal, just means rib, spinal column angle. So basically we just follow their anatomy or bone's name, then we name it. So that's some like a special anatomy, like a location, we name it. And clinically, if you find something, you're looking for anatomy name. Then we also have some line used in the chest area. In the center, in anterior, we call it middle sternal line. Still follow both names. And then we have clavicle bone, basically from here to here. Then we located the middle, from the middle of the clavicle bone. We make a line in there. We call it middle clavicular line. So then for the axillary area, axillary area, we have anterior axillary line, then we have posterior axillary line, and we have middle axillary line. We're looking for this picture. So follow anterior part, we have anterior axillary line. Follow the posterior part, we have posterior axillary line. And in the middle, we have middle axillary line. So we make so many lines here, means when we check it, we can go to special kind of area. And we also can record for if we find something in which part of the body. And everybody looking your recorder, they are immediately know where it is. Then we go to posterior, we go to back. So we have posterior middle line. The posterior middle line past like the pore size of the vertebrae. So that's just give you example here. C7. C7. But they will pass all of them. And then follow the middle edge of the scapular bone. So basically that's the scapular bone in here. Follow the middle edging of scapular bone. We make two lines here, which is named scapular line. Scapular line, both sides. So that's basically we use for our physical examinations. Then we look in the organs, the organs, like in the superficial of the body, what are they like physical location look like. That's the clavicle bone here, both sides. So pay attention, here is our lung. The top of the lung over the clavicle bone. And then on the right side occupied the most part of the chest. And we separate with 3 lobes. Right upper lobe. That's the right middle lobe. Then right lower lobe. So that's the words meaning there. Left side of the lung only have 2 lobes. That's the left upper lobe, like separate from here. Thus the left lower lobe, like in here. And certainly the respirations and will make the lung sometimes bigger, sometimes little bit small. So that's some distance here, like breathing in, breathing out, the lung size will be changing, both sides. Thus, we're looking from anterior part. If we're looking from posterior part, look like both sides of the lung look like pretty similar, because anterior part will have heart in left side here. But the posterior part, basically, both sides pretty similar. And still have moving distance here for people's breathing in, and the lung will getting bigger. So that's basically about our lung. This picture just looking from side. So certainly this is the right side of the lung. We say they have 3 lobes. Yeah, 3 lobes. So that's 1, 2, 3. Left side of the lung, just 2 lobes. They separate like upper, lower. So when we checking patient's body, we should have like a patient's lung picture in our mind. Then we know where we can checking for the lung. And then another important part, trachea. That's in the anterior. If we're looking from the posterior, still on the center, trachea should be in the center, not go to left side or right side. And then we have 2 mainly bronchi. Certainly we have more small bronchi later. So that's basically about anatomy part of the chest area. Then we talking about the physical examinations for the chest and the lung. So we say, when we talking about the physical examinations, we have 4 ways. We always do firstly inspections. So inspection means looking. Means we're looking for the chest area. We can looking like from posterior first. We standing behind the patients and looking, basically we looking the shape of the chest. We also can tell patient like walking a little bit, and then we looking their movement. So basically we see if both sides look like the similar, and the shape is the normal if they have some abnormal in there. So that's basically we looking. And we also specially looking some respirations movement on the both sides should be same. If one side moving faster, one side moving slow, that's abnormal. So that's basically we looking. Then we have some picture here. So certainly this picture is normal. We're looking by side. We're looking by side. And all of here is abnormal. Different kind of shape and size in there. Yeah, all of this is abnormal. So that's the inspections. Then we're talking about palpation. We palpation the chest area. Palpation means use your hand to feel the patient's body. Yeah, patient's body. Yeah. Practitioner's hand or doctor's hand. So I put a 2P here. Yeah. Doctor's hand. Doctor's hand to feel patient's body part. That's we say palpation. So when palpation the chest, basically we try to find if some like a tenderness in that area, or maybe like over the skin area, and also with palpation for respiration extensions. And the femoris, yeah, femoris is a special checking way when we checking the chest area. What that means? So now you can try to put your hand in your chest area. If you try to speak something, you can feel some vibrations in there. So that means femoris. So some sounds transmission make your chest area little bit vibrations. Then you can feel it. Yeah. And the respiration expansions means when follow people's breathing in, the lung will be moving. And you put your hand there, you can feel that kind of moving. So that's the palpation part. Certainly we're looking if some air, if painful or tenderness. Then we are still in the palpation part. We especially go to test for chest expansions. So let's go to the pictures here. So like these pictures here. So doctors put the hand below the rib cage here. Yeah, below the rib cage here. And holding there. Yeah, holding there. And then put your fingers little bit close each other. Then ask a patient, deep breath in. After patient's deep breath in, you will find your fingers moving aside a little bit. Means the distance here getting bigger. And certainly deeply breathing out, your fingers moving back, even more close. So that's the normal reactions for the patient. So that's the words here. Put the thumb on the level of the 11th ribs and the finger loosed, put in here. And then, ask patients inhale deeply. And watching the distance, they will be moving. Like a moving separate. Yeah. So that's basically normally both sides should be same. Yeah, both sides should be same. That's normal movement. If patient have illness in one side movement will be normal, another side is not moving. So that's one examination way for like test for chest expansions. So basically still mainly relationship with patient's lung functions here. And then we're talking about test for the firmness. So, like we just talked about before, firmness is the way we use doctor's hand still put on patient's body and then we ask the patient to speak something. When patients speak something, the vibrations will be transmitted from the bronchial tree to the chest area, and then we can feel it. Yeah. So that's the normal reactions. So like the picture here, we put hand, we compare left side and right side. Yeah, left side, right side. Put hand in the same level, like start from here, and then moving to here, and then moving to here, here and here. And we can tell the patient say like a E, a pretty long sound in there, or 999, or 111, yeah. So keep the same words, and then we compared both sides sounds in different levels. Generally speaking, if both sides sounds the feeling coming from your hand the same, that will be normal. If one side is more strong, another side is weaker, it be abnormal. Yeah, must be one side abnormal. Sometimes it's increased abnormal. Sometimes decreased is abnormal. Then we need a combination with other examination ways. So the picture here, we just put the location down the same level, top of the upper back, and then we compare there, and middle back compare, lower back compare, and the side of the chest compare. So that's the location for field firmness, which is compare the vibrations. When people speak, the sounds vibrations will go to the chest area. We will compare both sides. It should be normal. So that's the still belong to palpation. Still belong to palpation. With a palpation is use doctor's hand put on the patient's body. We can feel something. We can feel something. Vibration is still we can feel it. Then we talking about the percussion. So that picture is the location very percussionate. We go to next picture first, and then we come back. So percussion, basically we have two ways for percussion. One way is directly percussion. Means just use one hand. Like a tapping there. Like the picture here. But the difference with palpation. Palpation, just feel it. Let's see if you can see it. Palpation, just feel it. Just feel it. Percussion means tapping. Means tapping there. With hand tapping there. You can use fingers tapping. You can use palm tapping. That's percussion. That's percussion. That's palpation. So don't confuse it. And the palpation, mainly you feel something there. But percussion, you hear the sounds. Doctors hear the sounds coming from the percussion part. So that's different way. Don't confuse it. So that's directly percussion. If I use two hands, one hand putting on the bodies, on the patient's bodies, and then I use another hand over it. I just tapping my hand, but my hand touching for the patient's body. That's indirectly percussion. But generally say percussion, remember, we use doctor's hands. Doctor's hand put on the patient's body, but just tapping there. Tapping patient's body. and then hear the sounds coming from the patients. So that's percussion. Yeah, that's percussion. Pretty easy confusing palpation and percussion. Yeah, palpation, just feel it. Yeah, just feel it. Nothing relationship with the sound. Yeah, percussion, we hear the sounds coming from doctor's hand, tapping patient's body. So thus we have directly percussion, we have indirect percussion. Directly percussion use one hand. Indirect percussion we use two hands. Then we're talking about the location of the percussion. We still compare two sides of the bodies with percussion. Same level. The sounds coming will be the same. So we still start from top of the chest, upper back area. And then we second location here. And then 3 locations here, 4 locations here. Like we finish the first line, then we go to side of the chest. 6, 7. So basically, what kind of sounds we can hear? We hear the sounds coming from the lung. Kind of hollow sounds, yeah, kind of hollow sound, but not truly hollow, yeah, not truly hollow. We see percussion, we can find a lot of things. In the radio, the doctors try to find like how the lung expansion. So he asked the patient like a deep breathing in and then breathing out. The lung should be getting smaller. So let's see. So like these pictures, yeah. So the lung will be moving. Yeah, lung will be moving. Inhale and exhale. We say the lung sounds is kind of a hollow kind of sound. It's not totally hollow. We give it a special name, resonant. That's kind of sound coming from the lung. Yeah. And the liver under it. Liver is the solid organ. The sounds will be dull sound. So when people respirations, they will moving the diaphragm upward or downward. So the changing will be some changing happens in here. So they talking about 5 centimeters, just the changing difference, the sounds changing. So when people exhale, the lung getting smaller, the dull sound moving upward, and the restless kind of sound will be smaller area. When people inhale, the dull sound will be moving downwards, and the restless sound will be getting bigger here. So that's basically from the percussion, the sounds changing, we will know patient's normal respiration function in there. So that's basically in this part, inspections and percussions. So we know, pleural cavity is covered for the lung. So basically, when we're looking for the lung, it will be including the pleural area. Normally, they are pretty same. Normally they are pretty same. Because it's negative kind of air pressure in the pleural cavity. But in some abnormal conditions, there may be some difference. But normally, the aging will be the same. So that's just put a yellow color here for pleural cavity. And anterior part, anterior part, we have heart there. We have heart there. And the posterior part, basically, little bit difference. Right side, we have liver there. With left side, little bit difference. So that's basically, if we're checking from left side and right side, little bit difference. And this area is a kidney located area. So because right side we have liver there, that's basically make a little bit difference. Left side kidney little bit upper. Right side kidney little bit low, about half ribs lower on the right side compared with left side. So that's basically we can hear the different sounds coming from different organs by percussion. So that's we finish the back part, inspection, palpation, and the percussion part. Auscultation part, later on, we're talking about together. So now, we're moving to anterior part. Anterior part of the chest, inspection. Still start from looking. We're still looking the shape of the chest. And also, we're still looking the movement of the chest. So that should be the same. Both side movement should be the same. And then we're looking the shape. The shape still both sides like the same. And that's we still can see during the inspections some moving, some moving in there. So that's basically we're looking. Then palpations, then palpation. So palpation, we still try to find some tender area first. And then we still palpations we still can see like the chest expansions. So these ones still pretty similar like we do on the back. So now we put our hand below the ribcage area, beside the ribcage area, and still our fingers pretty close each other, and then ask patients inhale and exhale. So that we still can see some changing there. So that's basically by the palpation. Yeah, basically by the palpation. So that's we mentioned here, the hand along the lateral rib cage area, and then put like loosen skin between your thumb area. Ask patient inhale deeply, and then looking for the thumbs like discharging, the changing follow the patient's expanding, getting bigger, yeah, getting bigger space there. So that's basically we still expected both sides the same symmetry. So that's follow the respiration movement. That's one side we do the palpation, yeah, palpation. And we also palpation from one side, frontal side, anterior side. We palpation located for the trachea. We say trachea should be in the center. We use our two fingers fixed on the both sides of the trachea, and then looking if it is located in the center. So that's we checking for the trachea. Then we still feel the pharynx. The same thing like we do on the back. Yeah, the same thing like we do on the back. So still put our hand on both sides same level, and then tell the patient to say 999 or E, just like the patient's sounds, let it be longer in there. Then we can feel the vibrates coming from the hand. Yeah. So just make a pretty long sound in there. So we still compare both sides, upper, lower. But pay attention here. This location may be a little bit different, both sides. That's still normal, because this location is not the lung location, it's the heart location. But upper part should be the same. Side part should be the same when you compare them. So that's for the, like we still compare, let's still compare. And certainly we still need percussion. Yeah, we still need percussion. Anterior side percussion. But I believe percussion part mainly we go to the lung. So that's basically we put on the lung examination part. So Then we specially go to lung examinations. So basically, chest and lung examinations, pretty similar location. So like something we talked about before already, inspections, we looking the movement of the chest, respiratory movement. And certainly when we checking for the lung, we need to calculate respiration rate. When we're talking about vital signs, we say we have 4 important vital signs, including the heart rate, and including the body temperature, including the blood pressure. Another important part, respiration rate. So normally respiration rate 12 to 20 per minute. We calculate respiration rate like people after rest about 20 minutes. It's not like people just running and then coming in, and then we calculate respiration rate certainly increased. So generally say tell the patient rest about 10 to 20 minutes. It's depending how like exercises he do it. Like just walking in slowly, we can just take about 10 minutes. But if a patient truly do some exercises, just finished, we need more time to rest. Then we calculate. So that's the respiration rate. And the respirations like should be regular. Yeah, it's not like sometimes faster, sometimes slow. So regular rate is there. So that's from our inspections. So we're still talking about the physical examinations. We have 4 ways or 4 methods. The first one, inspection. The second one, palpation. Third one, percussion. Fourth one, aspiration. Now we're still talking about palpation. Palpation use our hand. Palpation for the patient's body. And feel something changing there. Yeah, just feel something. Feeling. Then aspirations still use our hand to patient's body, but the difference when hearing the sounds coming from the patient. So that's the difference. Yeah, that's different. That's feel here. Yeah, feeling something. Yeah. So what we can feel? Yeah, what we can feel? We can feel the chest will be changing or expansions follow patient's respiration. And also we can feel the fibers from the patient's sounds. Yeah. When people speak, patients speak something, we put our hand on the chest area, then we can feel the fibers. That's the palpation part. that's palpation part. When we're talking about the lung percussion, we're talking about use our hand, put on the patient's body, and then they hear the sounds coming from the patient. Yeah, hearing the sounds coming from the patient. So percussion in different parts of the patient's bodies, the sounds will be different. We say the lung basically is more air inside. So when we talking about the lung, mainly it's a small space here. Still remember that's called alveoli, and the air holding in the alveoli. So that's the sounds. It's a little bit hollow kind of sounds, but it's not truly too hollow. You can compare with your stomach. Stomach sounds, basically, especially upper part, stomach, it's truly air in there, no tissue in there. It's more hollow sounds in there. So for the lung sounds, like a half hollow, half dull, we give it a special name, resonant. Yeah, resonant sound, just we give a special name coming from the lung sound. You even can hear the sound with your percussion, your self-lung. Yeah, your self-lung. And then you compare with your stomach. Compare with your liver and compare your heart. The sounds will be different. Yeah, the sounds will be different. So that's basically you can percussion yourself and then compare the sounds coming from different part of body. The sounds will be different. But generally speaking, the sounds coming the lung, we name it resonant. Yeah, resonant. It's half empty, half dull. Yeah, between it. That's we use the word resonant. So that's the special sound coming from the lung. So that's basically in lung air, we can hear that kind of sound. So where is the lung air? Upper border, 2 to 3 centimeters over the clavicle bone. Lower border, we're talking about normal respiration. Yeah, not deeper breathing in, not deeper breathing out. So that's in the 6th intercostal space, in the middle clavicle line. Yeah, we're talking about where is the middle clavicle line before. So that means if you go to that area, your percussion, you can hear the resonant sound that belong to lung sound. We have picture here. Yeah, we have picture here. So we say upper border, this side is more bigger. Yeah. That's the clavicle bone here. Upper border is about 2 to 3 centimeters over the clavicle bone. So that's sometimes we're talking about, let be careful when you do acupuncture in the shoulder area. We have points, gallbladder 21 there. not too deeper and not go to long directions. You may injure the top of the lung in there. But generally it's a safety, not too deeper. So that's the upper border. And the lower border, we calculate the rib here. 1, 2, 3, 4, 5, 6. And the middle clavicle bone, middle line of the clavicle bone. So that means, that means here. So that's the upper border and the lower border. So when you percussion, you compare both sides. That's the resonance sound in there. And then when you go over 6 intercostal space below, that will be down sound. That will be down sound. So because the liver in there. This picture look like they make some difference here, like a pleural cavity. Look like a difference with the lung, but truly, normally, you couldn't separate like a pleural cavity sounds with lung sounds. They are pretty close together. So that's the normally lung sound through the percussion. And what kind of situation can changing the lung sound? What kind of situation? We say normally lung sound will be resonant kind of sound. But when people getting sick, the sound will be changing. The changing have 2 possibles mainly. One possible is changing like a more solitude inside. Like a patient got pneumonia, lung infection. It's more like a phlegm inside. And also some sick or illness happens in the pleural cavity. We say normally you couldn't separate pleural cavity with the lung. But for some illness, maybe some liquid go to pleural cavity. It's truly pushing the lung shrinking or lung collapse. So that kind of condition, the water here is more go to down sound. Or maybe in some part of the lung, is a tumor or cancer in there, the sound will changing to down. Another kind of condition is opposite. It's opposite. Is the more air go to the lung? So what kind of condition is more air go to the lung? So one kind of situation like bronchial tree have some trouble, like people have bronchiolitis for long term, and truly their alveoli, they are fusing together, like that's the normal alveoli. They separate the air in there, and they fusing together, and holding 2 air inside the lung, and the lung even getting bigger. So that's basically more air go in one situations. And also another situations we especially talking about still pleural, still pleural. More air go to pleural cavity, and still make the lung shrinking, but air go to upper part. Remember, air go in, go to upper part of the lung, and the water go in, go to lower part of the lung. Yeah. So that's like this kind of picture here. More air go in there. So when more air go in the pleural cavity, then if you go to this part of the lung, you can hear the more like a hollow sound. That's we say hyper-resonant. Yeah, hyper-resonant. So that's two kind of situations can changing the sound coming from the lung. We hear the sounds changing, we know some illness happens in different part of the lung. So that we still compare both sides. Yeah, both sides. So we compare both sides. Like that's the first line. Then we go to side of the chest for side part. We can use both for percussion and aspirations. Yeah, same picture. Yeah, same picture. Then we're talking about aspirations of the lung. Yeah. Lung examinations, we say we can use all the 4 ways examinations. Yeah, all the 4 ways. First way, inspection or looking. Second way, palpation, feel something. Third way, percussion, means we tapping the patient's body, we hear the sound. The fourth way, auscultations, we still hear the sounds, but the sounds not directly coming from our hand. It's coming, we use special kind of scope. I believe everybody see the doctors use this kind of scope and then putting on the patient's chest area and then hear the sounds. So auscultations means hear the sounds coming from the patient's body, but use special kind of scope. So certainly we have different form. Some form just one side you can hear the sound. Some form they may have both sides, little bit different size. The sounds will be little bit different. Yeah. But whatever is hear the sounds coming from inside the patient's body. Then we separate. It will be normal breathing sounds. Yeah, everybody will be high. Yeah, everybody will be high. Normal breathing sounds. Normal breathing sounds, we still separate 3 different parts. Means we can hear 3 different sounds from our chest area. One sound we call bronchial breathing sound. Then we talk about the location. Yeah, bronchial breathing sound. Another sound we call vascular sound. Then we have another sound basically between these two. Bronchial vascular breathing sound. So different part of the body, normally, we can hear the different sounds with this special kind of scope. Then we talk about where we can find it. Yeah, where we can find it. So we're talking about the vascular sounds first. Vascular sounds is like that's the bursting in sound, that's the bursting out sound. Like bursting in, let it be longer, bursting out, let it be shorter. And it's more softer. Yeah, it's more softer. The sounds is let it be lower sounds in there. So we say most part over the lung will be this kind of sound. We give it a name. Vascular sound. Vascular sound. Most part of your lung will have this kind of sound. Then we're talking about another sound. Another sound. Bronchi sound. Thus truly is more bigger, the sound more higher and louder. And you can see the chart here, like inspiration, expiration sounds pretty equal there. Pretty similar. So these bronchi sounds basically all over the the sternal bone, upper part sternal bone, mandible, that area. Thus normally we can hear these kind of sounds. So that's more loud. And we have another sound. We call trachea. So that means these sounds basically it only happens in the trachea area of the neck. It's more loud. But that's not commonly sounds. We hear the sounds from there. Basically, we just try to know these three sounds belong to our normal sound. So these sounds certainly still normal, but it's not that common, happens in the other part. And then we're talking about normal sound location. We hear the three different sounds from the radio already. That's all belong to normal sound. But remember, we say it normal. It must be in some special location. If they moving to other location, they may changing to abnormal. So the first one, basically, all over most part of both lungs, that's usually location not changing, but like how stronger may be changing. Like the radio we see, sometimes they may changing to weaker. That's still abnormal. But generally say location is not changing. The second sound, we call it a bronchivascular sound. It's like between the vascular sound and the bronchi sound there. So it usually located first and second intercostal space in anterior part of the chest. And also you can hear it between the scallop bone on the back. That's the normal location. Certainly, if they changing to other location, they still possible be abnormal. So that's the location. And the third one still the same thing. Yes, still the same thing. So location usually over the mandible. That's the first part of the sternal bone. And that's normal location. If you hear from other location, still abnormal. So that's basically the sounds we can hear normally coming from the lung. Yeah, normally coming from the lung. Some pictures just help you remember. Yeah, So that's different sounds coming from different parts. Then we may have a lot of different thick sounds. Yeah, a lot of different sounds. So we say normal lung sounds, most part of the lung, vascular kind of sound. And if they changing, patient will still say some sick or illness caused solely kind of changing, means maybe coming from pneumonia, maybe coming from the like tumors, or maybe some liquid in there. So basically that part of the lung will changing to bronchial sound. Means more sounds easily transmit. Yeah. If more air go in, like we talked about before, maybe go to the lung, maybe go to the pleural cavity. So that's basically, especially for pleural cavity, then you couldn't hear the sounds in the locally, like the lung polyps here. And certainly if you hear the sound from here, the air not truly transmits the sound not good. So that's the sounds will disappear. And also have some liquid there. The sounds still disappeared. So that's coming from the sounds changing, give us some basic idea what kind of sick or illness in the lung. So that's basically that's basically normal sound changing. We also have some abnormal sounds. Yeah, we also have some abnormal sounds. So like, especially like people have pneumonia, like some phlegm go to inside of the lung and blocking the bronchial there. We can hear more sounds, different kind of sounds. Or people arthritis, yeah, the bronchial tree spasm in there, the air passing difficult. So that can cause a lot of different abnormal sounds. So that's the sick sound. So right now, I just give you an example, but you are not truly need to remember all the abnormal sound. So that's just give you some basic idea how normal sounds and how abnormal sounds look like. Clinically could be like a lot of different kinds. But generally say abnormal sounds. The sounds is just normal breathing sounds and plus some like noise. That kind of noise is coming from the something blocking the air passing way, make it difficult to go in or go out, then make a different kind of sounds in it.